I'm lost in your haze where the lights are low, drowning in the depths of your eyes. I'm ready to go. In the shadows we'll find our way. Through the night our love will stay. In your love I'm lost, I'm found. In your heart my home is bound. Forever I'll be yours, you'll be mine. Lost in your haze, our love will shine. In your love, I'm lost, I'm found. In your heart, my home is bound. Forever I'll be yours, you'll be mine. Lost in your haze, our love will shine.
The mimetics. So yes, as you've heard, they are speed. Amphetamine is speed. Although I should say if they take methylphenidate, Ritalin, or Concerta or something of that sort, that's not amphetamine. Nonetheless, it's a stimulant. It's a sympathomimetic also. These are kids that are taking these drugs during development, and therefore levels of dopamine, levels of norepinephrine are being increased in their brain and body. And you might say, well, wouldn't that lead to a craving for these things later in life? And that does not appear to be the case. In fact, there's some very nice neuroimaging studies, mainly positron emission tomography studies that I'll provide a link to in the show note captions that show that early treatment with these drugs actually leads to combinations of increased dopamine transmission in the forebrain later in life at a lower level, or a lower threshold, I should say, in a way that essentially says there's normalization of the circuits across time by the application of these drugs early in life. Again, in the case of children that have diagnosed ADHD, I in no way, shape, or form want to imply that all children should be treated with these drugs. That is quite clearly not going to be a good idea. So all of this really speaks to the critical importance of getting an accurate diagnosis of ADHD. You know, diagnostic criteria include many things. In children, there are multiple. There are more than 9 diagnostic criteria for each of the categories relating to impulsivity, hyperactivity, and so on. So a well-qualified psychiatrist will do several things. They will, first of all, do a careful diagnostic evaluation of a child. And in addition, one would hope that they would think about prescribing both appropriate pharmacologic treatments for ADHD, but also be aware of and prescribe the various other types of prescriptions, meaning behavioral prescriptions. So there are clearly certain learning tools and things that kids can do in order to improve their ability to focus and to be less impulsive that combine especially well with drug treatments, as well as new advancements in the realm of nutrition and supplementation that are constantly coming online. And the best psychiatrists are going to be tuned into all of those aspects of treatment for ADHD, not just prescription drugs, but also behavioral treatments, also nutritional guidelines, also supplementation, and also updating each and all of those things as a child matures from each stage of development to the next. I'd like to take a quick break and thank our sponsor, Inside Tracker. Inside Tracker is a personalized nutrition platform that analyzes data from your blood and DNA to help you better understand your body and help you reach your health goals. I've long been a believer in getting regular blood work done for the simple reason that many of the factors that impact your immediate and long-term health can only be assessed with a quality blood test. The problem with a lot of blood and DNA tests out there, however, is that they'll give you information about certain lipid markers or hormone markers, but no information about what to do with all of that data. Inside Tracker makes it very easy to look at your levels of hormones, metabolic factors, lipids, etc., and then to assess what sorts of behavioral, nutritional, supplementation, or perhaps other interventions you might want to use in order to bring those numbers into the ranges that are optimal for your health. Inside Tracker's ultimate plan now includes 3 new hormone markers that are critical to measure during a woman's reproductive and menopausal years. These are estradiol, progesterone, and thyroid stimulating hormone. If you'd like to try Inside Tracker, you can go to insidetracker.com/Huberman to get 20% off any of Inside Tracker's plans. Again, that's insidetracker.com/Huberman to get 20% off. Now, the other common question is, if a child has been treated with these ADHD meds during development, do they need to continue on those drugs indefinitely? And the short answer to this is it depends. And that can be a somewhat frustrating answer, I realize. But the good news is it's something that can be assessed in a fairly straightforward way. Let's recall that the use of these drugs to treat ADHD is designed to accomplish two things. It's designed to improve the function of those neural circuits that allow a child to focus. And it's also designed to increase the strength of those circuits, to effectively teach the circuits how to learn what focus is. In other words, these drugs are designed in some cases to be used and then withdrawn later because the circuits that they helped build up are functioning well. In some cases, however, the circuits that underlie focus are not going to be able to function at the level required for normal, healthy life progression unless there's continued application of the drug. So how would this work in the real world context? Well, I think any child or adolescent or person younger than 25 that's taken these drugs has no doubt achieved some level of neuroplasticity of the neural circuits related to all the things we call focus. And I want to be very clear. There's no single brain area or set of brain circuits for what I'm referring to as focus, because after all, focus involves task switching, focus involves all sorts of different cognitive operations depending on what we're focusing on. Right? The focusing on a sport is basically a practice of directing one's attention in different locations at different moments. Focusing on studying is an entirely different pattern of focus altogether. But the point being, if a person 25 years or younger takes a drug that increases dopamine and norepinephrine, and assuming that things are working, meaning the dose is right, they're achieving better ability to focus, etc., those circuits are going to get stronger. And it seems entirely reasonable. In fact, it was supported by the psychiatrist that I spoke to prior to this episode, that people who've been on ADHD meds for any point of time prior to 25 talk to their psychiatrist about what tapering off those drugs in order to examine whether or not they still need those drugs would look like. Now, I mentioned the word taper because there is a withdrawal potential of simply stopping these drugs very quickly because they do ramp up dopamine and norepinephrine. Even though they increase plasticity of the neural circuits for focus and mood and motivation, if one very abruptly ceases taking any of these drugs, it does not feel good. That drop in dopamine that one inevitably experiences is almost always associated with lethargy, with depressed mood, with feeling not good in a number of ways, and of course, challenges in focus. So anytime one is going to go off one of these drugs or sample what it is to even reduce dosage, that has to be done in close communication with a board-certified psychiatrist. At the same time, it was made very clear to me from ADHD expert psychiatrists that reductions in dosage over time often are optimal for a patient. Okay. And this gets to the whole issue of dosage generally. I spend a good amount of time talking to somebody who prescribes these drugs, both to children and adults, about dosage ranges. And I don't want to spend too much time on this from the perspective of how much one should take. In fact, I don't want anyone to think that what I'm about to say should dictate what they should take specifically, because that's something that really has to be worked out on an individual basis. But it is worth noting that if you look at the studies on Adderall and methylphenidate, what you'll see is a pretty broad range in those studies. And that's because some of the studies used people that were already taking these drugs and asked them to participate in neuroimaging studies. Other studies actually put people on these drugs for the very first time or adjusted their dosage. And so you'll see a tremendous range of drug doses explored. For instance, you will see anywhere from 10 to 40 milligrams of Adderall per day. You'll see anywhere from 10 to 60 milligrams of Ritalin per day. And here we could easily be talking about studies on children or adults. With respect to Vyvanse, you'll see that the dosages tend to be much higher. In part, that's because Vyvanse has, if you recall, it's that lysine, which is a big molecule, stuck on D-amphetamine, which is a smaller molecule. And so the dosages of Vyvanse tend to be in the hundreds of milligram ranges. But most of that 100 milligrams of Vyvanse is not going to be the D-amphetamine. It's going to be the lysine, which doesn't do anything in the context of treating the brain. It's just there to control the slow release. So it's thought that 100 milligrams of Vyvanse translates to roughly 9 milligrams of Adderall, and on and on. And actually, it's pretty hard to translate between dosages of different drugs in any direct way. And in speaking with a psychiatrist expert in ADHD in preparation for this episode, he made very clear that it is extremely, extremely difficult to predict how a child or adult will react to a given dosage of any of these drugs. So much so, in fact, that he anecdotally reported to me that one of his patients is a male, 300 pounds, diagnosed with ADHD, and who achieves tremendous relief from just 2.5 milligrams of Adderall per day. And at the same time, he has two patients, both of whom are sisters, so they're genetically related, who are in the 120 to 140 pound range, who did not respond well at all for the treatment of their ADHD until their dosages were very, very high. And if I tell you these dosages, I just want to warn you in advance, I'm not suggesting anyone explore these dosages without, of course, the approval of their psychiatrist. Turns out that neither of these two young women responded at all to ADHD medication until they achieved dosages in the range of 180 in the case of one sister and 240 milligrams in the case of the other sister per day, which is an astronomically high dose on the face of it. But this physician, again, board certified physician, expert in ADHD, verified for me that indeed neither of them experienced any discomfort or side effects that led them to not want to take the drug. But of course, that amount of Adderall could send somebody else into an absolute psychotic fit, could potentially even cause cardiac arrest. I mean, it's remarkable the ranges of Adderall that are used effectively in children and adults. And this is true for a lot of the other sympathomimetics used to treat ADHD. And of course, a good psychiatrist will always assess dosage as it relates to positive benefits, relief of symptoms. So relief of impulsivity, relief of hyperactivity, improvements in ability to focus. And of course, they are going to consider side effects, any uncomfortable adverse effects that come from taking the drug at a given dosage or taking the drug at all. Now, of course, this all begs the question of why such tremendous variation. Is this due to genetic differences in the amount of dopamine or norepinephrine that people make? It appears that the major underlying factor for why people require such vastly different dosages of these sympathomimetics for the relief of ADHD has to do with the different enzymes or levels of enzymes that people make which metabolize these drugs both in the brain and body. And unfortunately, there is no simple blood test or saliva test or test of any kind that can predict how someone will respond to these drugs. So the most logical and safe way to assess dosage is to start with the lowest possible effective dose and to increase only as necessary in order to achieve the positive benefits, while of course paying attention to any side effects that might arise. A question that comes up from time to time when discussing the long-term effects of drugs like Adderall, Ritalin, and Vyvanse is whether or not they can negatively impact height or growth or development in some other way. This is a logical question to ask because, after all, these drugs are effectively mimicking stress in the body. And most everyone has heard by now that while stress can help us in the short term, it helps us deploy immune molecules to protect us against infection. It sharpens our visual focus and our ability to respond to things for survival. Chronically elevating our stress over long periods of time, we know reduces the effectiveness of our immune system and can actually cause certain forms of brain degeneration. And while there aren't a lot of longitudinal studies on the heights of kids with ADHD, and of course, we never can tell how tall someone would have grown to be if they were treated with a drug because we don't have a perfect control experiment, even in the case of identical twin experiments. And there aren't that many of those examples where one twin was treated for ADHD and the other wasn't, etc. But here's what we know. It does not appear that treatment with sympathomimetics during development, provided the dosages are kept in the appropriate ranges, is going to limit overall height. In fact, if you look at the data, it appears that children with ADHD who are treated with ADHD meds actually arrive at slightly higher BMIs, body mass indexes, compared to age-matched peers. Now, of course, body mass index doesn't necessarily correlate with height, right? Someone could not achieve a full height, but could be heavier, either through bone or fat or muscle or combination of all three. But what we know is that the appropriate use of ADHD meds during development is not stunting development in any kind of overall way. It's not preventing maturation of the body in ways that are leading to reduced weight or somehow impaired growth overall. With that said, long-term elevations of sympathetic nervous system activity does carry some risk. And one of the primary risks that people have wondered about is cardiovascular risk. And this makes perfect sense, right? When you increase the activity of the sympathetic nervous system, you increase blood pressure, you increase heart rate, you increase, in some cases, peripheral sweating, all the things that we associate with stress. So you can imagine that a child or adult with ADHD that takes these sympathomimetics every day, even if the dosage is kept in a range that doesn't allow them to experience any immediate untoward side effects. So they're not feeling miserable, they're just feeling like they can focus better. But one always wonders what's going on under the hood, so to speak. There is, as far as I know, one major study that's addressed this, and the conclusions of that study were a little bit hard to put into a single category. It did point to a subtle increase in cardiovascular risk, but the results did not point to anything so dramatic that the authors of the study warned against taking these drugs or encouraging people to cease taking these drugs, again, provided they're being prescribed by a board-certified physician for ADHD and at the appropriate dosage for that person. That said, I think this all again speaks to the importance of arriving at minimal effective dosage. And it stands to reason that if you're somebody who's taking ADHD meds, or if your child is taking ADHD meds, that one would want to do all the other things that they could do in order to try and improve cardiovascular health, or at least not put it at additional risk. So those are going to be the obvious things like avoiding smoking or vaping nicotine. Regular exercise is going to be encouraged, and things of that sort. And that dovetails into a bunch of other questions that are often asked anytime the topic of Adderall or Ritalin comes up, which is, what about alcohol? Is drinking alcohol at the same time or at different times even going to be problematic if one is taking these drugs? Is taking benzodiazepines going to be a problem, et cetera, et cetera? There's a very straightforward answer to this, which is it's very clear that alcohol, certainly in children, but also in adults, is best not consumed. I did an entire episode about alcohol, which got into this and the data for this. If you've heard that having some alcohol, in particular red wine, is better for you than no alcohol, that is simply not true. I'm sorry, it's not true. Most adults who are not alcoholics can probably have up to two drinks per week and still be on the safe side of health, although 0 is better than 2. And once you get past 2, you start seeing effects on various systems, including increased cancer risk, especially brain neuron loss and degeneration risk. I covered all of those data in the episode on alcohol that you can find at hubermanlab.com. Combining alcohol with sympathomimetics, even though they reside in very different pathways within the brain, in fact, the sympathomimetics are driving up sympathetic nervous system activity, whereas alcohol is actually doing the opposite. It's depressing it. And yet all the data point to the fact that combining alcohol with sympathomimetics, such as Vyvanse, Adderall, Ritalin, or any kind of amphetamine, is going to be more detrimental to the brain and body than simply taking those drugs on their own. Put differently and more directly, if you are taking any of the drugs that we've been talking about to treat ADHD, or if you just happen to be taking them for whatever reason, you are going to want to avoid drinking alcohol at any time, and you're going to want to avoid benzodiazepines and similar unless they've been prescribed to you by your physician. In advance of this episode, I put a call out on social media for questions about Adderall, et cetera, and I got a lot of questions about whether or not there are impacts of these drugs on the hormone systems of the body and if they impact the reproductive system in particular. I also got questions about whether or not these drugs impact sexual behavior or libido or anything of that sort. In reviewing the literature, what I can tell you is that there are very few studies, unfortunately, of the long-term effects of these drugs on the endocrine or hormone systems of the body. But we do know a few things for sure. First of all, when you increase the activity of the sympathetic nervous system for long periods of time, you are very likely increasing levels of cortisol. Cortisol is a quote-unquote stress hormone, but cortisol also plays some really important positive roles in your body. In fact, you want cortisol released, especially early in the day. You don't want cortisol released so much late in the day. This actually relates back to timing and schedules of taking drugs. This is something, again, that needs to be worked out with your psychiatrist or your child's psychiatrist. But one of the reasons why there are so many different drugs for the treatment of ADHD is that each and all of them has a different time course of action. So Ritalin is very short-lived, which might sound bad because then you have to take it multiple times throughout the day. But if you think about from the perspective of sleep and the importance of having low cortisol at night, and these drugs increase cortisol, and the importance of getting sleep, because after all, sleep is the foundation of mental health, physical health, and performance in kids and adults. It's responsible for growth. It's when neuroplasticity happens. It's just so vitally important. A lot of the drugs that we've been talking about can severely limit one's ability to fall and stay asleep. And so a short-acting drug like Ritalin is actually attractive from the perspective of being able to take it in the morning and still get to sleep at night, or taking it in the morning and in the afternoon, and maybe even again in the evening, depending on the person, and then still being able to fall asleep at night. Whereas long-duration release of D-amphetamine, which is what you get when you take Vyvanse, for some people is going to inhibit their sleep. They'll get a nice steady rise and improvement in focus and reduction in hyperactivity, but they might have a lot of trouble falling asleep at night. And Adderall, having a somewhat intermediate time course of action between Ritalin, which is short-lived, and Vyvanse, which is very long-lived, perhaps is going to be the best solution for somebody else, where they can take it early in the day, perhaps at a low dose, maybe again later in the day, low dose, and then still fall asleep at night. But I've spoken to people, and I've spoke to this clinician expert in ADHD who told me that some people will take as little as 2.5 milligrams of Adderall at 6 a.m. and have a hard time falling asleep later that night at 11 p.m. So again, vastly different sensitivities to these drugs, leading to vastly different requirements of dosage and timing of intake, and which particular drug somebody might choose to or choose not to take. So how does that relate to hormones and sex and reproduction? Well, cortisol itself is a hormone. It can act as a bit of a hormone and a neurotransmitter in the brain, but for the most part, it's acting as a hormone in the brain and body, and it does a number of things. First of all, it can enhance your levels of focus and alertness. It can activate your immune system. I know the immunologists out there just cringe when I say activate the immune system. Your immune system is always doing various things. So it's always active, just as your nervous system is always active. But it can, to be specific, it can amplify or mobilize the release of anti-inflammatory molecules in your brain and body to combat different types of bacterial, viral, and fungal infections. It's doing an enormous number of positive things. It's also involved in setting mood. It has interactions with thyroid hormone pathways. I've done entire episodes about cortisol and cortisol regulation. To paint all of that with a very broad brush and briefly now, it's advantageous to have your cortisol release high in the early part of the day and to taper off toward the end of the day. In fact, late day elevations in cortisol are a strong correlate of depressive symptoms. This was demonstrated by my colleagues David Spiegel and Robert Sapolsky at Stanford School of Medicine. But that is not to say that cortisol is bad. It's to say that the timing of cortisol release is key. So, do these sympathomimetic drugs disrupt the endocrine system? Well, they can. If you are very awake and very alert, regardless of whether or not you're taking your sympathomimetic treatment for ADHD early in the day or late in the day, you are very likely experiencing elevations in cortisol late in the day. So it is important, even for those of you that like to study and need to focus in the evening and nighttime hours, that you try and limit your levels of overall alertness and certainly stress late in the day, because doing that day after day after day for several weeks or months or years can indeed disrupt other hormones in the endocrine system. And again, that's because cortisol is interacting with thyroid hormone and testosterone and estrogen. In fact, cortisol in many ways competes with or can outcompete for the production of testosterone and other so-called steroid hormones. Remember, cortisol itself is a corticosteroid hormone. So when we hear the word steroids, oftentimes people just think about athletes and steroid abuse in sports. But steroid hormones includes a lot of different types of hormones which are good for us. Our endogenous steroid hormones are vital for all sorts of things, vitality, reproduction, etc. And the way this works in general terms is that the cholesterol molecule is used to create testosterone and cortisol and estrogen if we make too much cortisol, we in many ways are reducing the total amount of testosterone that we make or that is active. It's not exactly that straightforward, but we can make that statement with confidence. For instance, if you spike your cortisol just briefly during the day because you have some sort of stressful event, that's not going to inhibit your testosterone. In fact, it probably is going to boost your testosterone levels somewhat. However, if your cortisol levels are chronically elevated, yes, indeed, it's likely that you're going to suppress your total and or free unbound forms of testosterone. And downstream to that, you will experience effects such as reductions in libido, reductions in muscle and bone mass, reductions in all sorts of aspects of testosterone-related psychology and bodily biology. This is true for both males and females, and the same thing could be said for estrogen. Now, what's impossible for us to say is whether or not taking a given treatment for ADHD is going to, for instance, prevent a woman from ovulating. That could happen through chronic elevations in cortisol, but there's no direct link, meaning there are no studies, at least that I'm aware of, showing that people that take Adderall have irregular ovulatory cycles or that they cease menstruating entirely. I don't think there's any evidence for that whatsoever, nor is there any evidence that people that take Adderall or other sympathomimetics for the treatment of ADHD have lower overall testosterone. In fact, you can imagine all sorts of instances in which the opposite was true, that a child or young adult or adult who has ADHD but then goes on these meds to improve their symptoms is now focusing and achieving more in life. We know that happiness can impact dopamine and vice versa, and testosterone levels, and productivity itself and reaching our goals can feed back on the hormone system. So anytime there's a discussion about hormones or a study that shows that doing X or not doing Y impacts hormone levels of a given type, we have to be very careful to make sure that we're talking about causality, because all of these hormones are in a very intricate crosstalk with one another. We can, however, make a very general statement, which is that when you are in states of stress for long periods of time, that is not a favorable condition for your immune system, your hormone system, or frankly, any other system in the brain and body. So the treatment of ADHD with these drugs should never be done at the expense of these other critical biological systems. Another common question and concern is whether or not kids, and I suppose for that matter, adults, that take medication for ADHD are basically being predisposed to psychosis and or other forms of addiction. And earlier we talked a bit about the risk for addiction, and the take-home message there is very clear that kids and adults that are treated for ADHD appropriately, so with the appropriate dosage of the appropriate drugs, under the supervision of a board-certified qualified psychiatrist, are at less risk for forming addictions to other substances in adulthood or other substances generally. I think a lot of people also wonder whether or not those kids and those adults that take these ADHD meds become addicted to the medications themselves. That's a bit of a tricky issue to resolve. Anytime one stops taking a drug or even tapers off a drug that's used to treat something where they feel better on the drug, they are going to experience two sets of effects, and these two sets of effects are often confounded with one another. One is the withdrawal effects, so the effects of removing the drug that make somebody feel less good than baseline. So, for instance, a kid that takes ADHD meds until their late teens or early 20s decides they're going to taper off. They do that, and they're feeling lousy during the taper or when they reduce their dosage to zero. They're, foggy brain, they can't focus, they feel a little bit depressed mood. It's unclear whether or not those are withdrawal symptoms or whether or not those are the consequence of not having the systems in their brain activated the way that those systems were activated before. I realize that for some of you that might seem like the same thing, but that's not necessarily the same thing. And probably the best analogy would be something along the lines of a hangover, right? If somebody drinks too much on a given night, the next morning they have a hangover. The hangover makes them feel lousy. It is actually a withdrawal from alcohol effect. But then when they recover from the hangover, they realize that their sober state, it feels pretty good. It doesn't obviously feel the same as being on alcohol, but that sober state is not a state of withdrawal. Okay, if we were to look at removal or tapering off of ADHD meds, there's going to be a period of withdrawal symptoms, but then the real question is, how does somebody feel after they get through those withdrawal symptoms? So that's an important issue to highlight. Now, in terms of psychosis, this is a very interesting and very important literature. First of all, any amphetamine, whether or not it's D-amphetamine, L-amphetamine, and also methylphenidate for that matter, Ritalin, can induce psychosis. Now, there are a number of different factors that are going to predispose somebody to psychosis. Having a first relative who's had psychotic episodes, either schizophrenic episodes or bipolar episodes, is certainly a strong predisposition. Of course, if an individual themselves have had psychotic episodes, that's the strongest predisposition that one could imagine. So having a first relative with schizophrenia or with bipolar depression, or it's sometimes called bipolar disorder, sometimes it's also just called bipolar these days, is going to be a strong predisposition for psychotic episodes, made much greater anytime one takes a sympathomimetic drug, such as amphetamine, but also methylphenidate, Ritalin, is going to increase that likelihood of psychotic episodes. Then comes the question of, if somebody has a psychotic episode as the consequence of taking any of these drugs, whether or not it's been prescribed for ADHD or not, will those psychotic symptoms go away after the person stops taking the drug? There appears to be a divide in the literature, or rather a divide according to drug, such that people that take Ritalin, methylphenidate, and have a psychotic episode, often, not always, but most often, if they stop taking methylphenidate, the psychotic episode will cease. It's not always the case, but most oftentimes it will cease. Whereas in individuals who have a predisposition to psychosis, or even if they're not aware of a predisposition to psychosis, and they take Adderall, which, as you recall, is a combination of D and L-amphetamine, they can have psychotic episodes that sometimes are very long lasting, even after the cessation of the drug. And while that might sound kind of shocking and really scary, and indeed it is scary, it perhaps shouldn't shock us that much, because if you recall D-amphetamine, which there's a lot of in Adderall, it's a very potent way of increasing dopamine. And anytime you potently increase dopamine in a person who has a predisposition to psychotic episodes, you are shifting the whole system toward a greater propensity for psychosis. This would also be the appropriate time to talk about methamphetamine. Again, methamphetamine is considered an illicit drug, a drug of abuse. It is responsible for a lot of the misfortune and tragedy that you see on the streets of major cities and even outside of major cities in rural areas. It has all sorts of negative effects on health, including oral health, cardiovascular health. It is neurotoxic to serotonergic neurons, so it kills serotonin neurons. That is absolutely clear. It kills dopaminergic neurons. That is absolutely clear. One of the ways that methamphetamine creates so many of the problems that it does, meaning effects on the body, abuse potential, addictive potential, the fact that methamphetamine can spark psychosis in those that have a predisposition to psychosis, but also that it can create psychosis in individuals who have no predisposition to psychosis. Right? All of this points to methamphetamine just being a terrible drug all around. And yet, if you recall back to the beginning of the episode, there is one form of prescription methamphetamine, but its uses are extremely narrow, and it's probably best left out of this conversation because its uses are so narrow in the clinical sense. I managed to talk to one expert. This is a board certified psychiatrist who's expert in ADHD, who is also very familiar with the psychosis symptoms induced by methamphetamine and by various ADHD drugs in people who have the predisposition. They made it very clear that any of the sympathomimetic ADHD drugs that are of the amphetamine variety, so that would be Adderall and extended release Adderall, it would be pure dexedrine, or any variants that include amphetamine, are going to have higher likelihood of inducing psychosis in people that have a predisposition to psychosis. And yet they did assure me that at appropriately prescribed and safe dosages, that the total incidence of psychosis in people that take those drugs is still fairly low and not that much greater than in the general population. Although there is an increased risk, it's not that severe. And they also highlighted the fact that methylphenidate Ritalin carries a lower potential for inducing psychosis, not zero, but a lower level of inducing psychosis than for the amphetamine type sympathomimetics. Now, one exception is Vyvanse, that long-release D-amphetamine that we talked about earlier. There does seem to be something protective about that long duration release of D-amphetamine that occurs with Vyvanse, which is not to say that there's zero abuse or addictive potential with Vyvanse. I was told by this same individual that indeed they've had knowledge of patients trying to increase the rate of absorption of Vyvanse and release of Vyvanse, or technically of the D-amphetamine, in order to get more of a high from Vyvanse as opposed to just the extended release. But they did assure me, however, that Vyvanse seems to be associated with fewer psychotic episodes and less abuse and addictive potential overall, which again is not to say that it's a perfectly safe drug. But really, this just highlights the fact that the kinetics or the time course of dopamine and norepinephrine release that's caused by a given drug is going to correlate very strongly with its abuse potential and addictive potential and its potential to induce psychotic episodes. And this is where the discussion about meth becomes especially relevant. One of the reasons why meth is so dangerous in terms of its addictive potential and its potential to induce psychotic episodes is, first of all, how much dopamine it releases. Again, 5 times more than any of the other drugs that we've been talking about, but also how fast that peak comes on. It's a very fast onset. And that's true whether or not people are snorting it, whether or not they're taking it orally, or especially if they inject it intravenously. But meth, because it increases dopamine so fast and to such a great degree, and then the peak in dopamine comes down very fast as well, and it drops below the baseline levels of dopamine that were present initially. That's one of the reasons why methamphetamine is so dangerous in terms of addiction and in terms of psychotic episodes. This gets back to a bunch of issues we've talked about before on the Huberman Lab podcast about dopamine kinetics. And I've done 2 episodes on dopamine that I'll refer you to. One is called Dopamine Motivation and Drive, which is all about dopamine and regulating dopamine. And the other one is about optimizing dopamine. It's more of a toolkit focused episode. Both of those you can find at hubermanlab.com. But the general takeaway that's relevant for what we're talking about now is that with dopamine, it's not just about the absolute levels of dopamine that are reached, but how long lasting those increases in dopamine are. So with Vyvanse, even though Vyvanse is D-amphetamine, it's fairly potent, not as potent as meth, but fairly potent at increasing dopamine and norepinephrine. It's a long extended release in dopamine and norepinephrine, which reduces its overall abuse potential because it doesn't tend to create that immediate euphoria and high and then crash below baseline. A lot of you will hear that it increases dopamine a lot and then stays up, as translating to, okay, well, then you're just euphoric for 16 hours. But that's not the case. When it comes to dopamine, it's an issue of how high that peak is and whether or not that peak is stable or whether or not it comes down again. And when it comes to psychotic episodes or addictive potential, it seems that any drug or behavior that increases dopamine very quickly and then brings dopamine down very quickly is what sets the high potential for addiction and abuse and for inducing psychotic episodes. So that's why I'm talking about these 2 things in parallel. And now it should be very clear why Vyvanse doesn't have so much addictive and abuse potential and has at least lower potential for inducing psychotic episodes. And it should also be clear to you that for people who do not have ADHD as a child, or for people that do not have ADHD in adulthood, if they were to take truly any of the compounds that we're talking about thus far, methylphenidate, Ritalin, Adderall, Vyvanse, dexedrine, and certainly methamphetamine, what we observe from neuroimaging studies is that these people get enormous increases in dopamine. They're not familiar with these drugs, so the increases in dopamine are just cosmic for them. They experience a lot of euphoria. Even if the dosages are low, the euphoria is associated with a very heightened degree of focus that they've never really felt before. Here, what I'm talking about is a lot of the recreational and off-prescription use of Adderall and things like it. And what we know is that that sets in motion both a potential for abuse and addiction to that feeling and substance, as well as a higher potential for psychotic episodes down the road. Okay, so put differently, children who have ADHD and are prescribed any of these drugs, or adults who have ADHD and are prescribed any of these drugs, who take them for some period of time, are actually at lesser risk to all of the issues related to having chronically elevated and greatly elevated dopamine as a kind of first-time event or as a rare event. Whereas anyone who takes these drugs without a prescription and decides, okay, I want to focus more, or I'm going to use this to stay up for a couple of days, in other words, using it recreationally or using it for quote unquote performance enhancement, is at far greater risk for addiction to these substances because of the amplitude and the time course of dopamine that results when one takes these drugs just out of the blue. And so for that reason, I really want to caution everybody against using any of the compounds that I've discussed thus far unless it's been prescribed to you by a physician for the specific purpose of ADHD. Now, I'm sure someone out there is screaming from the back, wait, if a kid takes these drugs because they're prescribed them for ADHD, the very first time they take them, they're going to have a huge amplitude dopamine response. Or if an adult goes in and talks to their psychiatrist and says, I'm having issues with focusing, and they're prescribed one of these meds for ADHD and they take it, they're going to have a huge amplitude dopamine response. Isn't that going to set in motion all the same things that somebody who is using these drugs recreationally would have? And indeed, that's one of the reasons why a lot of psychiatrists will start with a very low dosage, or the lowest possible dosage, to see how somebody responds to that low dosage. And then over time might or might not increase that dosage. In fact, they might even bring it down further, depending on how sensitive somebody is to the drug. But equally important is the fact that it is the repeated taking of that drug by the child with ADHD or by the adult with ADHD that actually leads to lesser and lesser peaks in dopamine each time, which is not to say that the person becomes entirely desensitized to the effects of the drug, but rather that the system equilibrates through what's called homeostatic plasticity. It's sometimes referred to broadly as habituation to a drug. But there are systems in the brain and body that regulate the connections between neurons so that if dopamine and norepinephrine are elevated above baseline levels for a while, the system normalizes so that instead the connections between neurons become stronger and there isn't the critical requirement for all that increase in dopamine and norepinephrine. I realize that might sound a little bit technical, but basically what I'm saying is the response that somebody has to taking a drug for the first time is far and away different than the response to a drug that somebody has if they are taking the same drug day after day after day. This gets to another issue, which is not discussed that often these days, but that is really important. If you go back to the original clinical literature on these sympathomimetics, what you'll find is that the original use of these sympathomimetics to treat childhood ADHD suggested that children not take these drugs every single day. Now, I'm not recommending that kids take drug holidays because I'm not a clinician. I'm not promoting any specific dose or dosing regimen. But in speaking, again, to a psychiatrist expert in ADHD, who, by the way, is going to be a guest on this podcast in the not too distant future, what he told me was that many of these drugs were designed to be taken during the school week for children with weekends off, or during the school year with weekends off, but then also with vacations during the summer holidays. And that these days, rarely, if ever, is that the pattern of intake that these kids are following. And why that is has interesting sociological and financial explanations. I'm not alluding to any kind of conspiracy here, but this is an aspect of the dosing with these drugs that has sort of fallen away in recent years, but I think is really interesting. And it's something that actually was supported for the treatment of adult ADHD as well. Again, there is a very different biological and neuroplastic response to taking a drug once versus taking a drug for, say, 5 days and then taking weekends off, to taking a drug over and over again every single day for a pattern of years. And when exploring the literature in preparation for this episode, I confess it was a bit dizzying to find answers to what are the long-term effects of taking Adderall, or what are the long-term effects of taking Vyvanse, etc. In fact, most of the literature on the long-term effects of taking drugs to treat ADHD has focused on methylphenidate, on Ritalin. There are studies on Vyvanse and Adderall, and actually those were the studies that I will link in the show note captions primarily, because that's where most of the interest is these days. The reason why so many of the studies have focused on methylphenidate, on Ritalin, is largely because that was one of the first drugs used to treat ADHD. So in terms of addressing long-term effects of kids treated with ADHD meds, those kids are now adults and therefore can be neuroimaged and assessed, whereas a lot of kids that have been prescribed Adderall or Vyvanse or similar have not yet made it to stages of life in which we can answer that question directly. There are a few studies, and I've made it clear to include those studies in my description of results today. In particular, the result I talked about earlier, where there's an improvement in executive function in kids that have taken ADHD meds or adults that have taken ADHD meds for a longer period of time, anywhere from months to years. Those studies did include both Adderall and Vyvanse and methylphenidate. And again, I'll link to those studies. But by and large, most of what we know about the long-term effects of any of these drugs has to do primarily with studies of methylphenidate. I'd like to spend a little bit of time talking about some compounds that are not considered amphetamines at all, but that are now being used to treat ADHD both in children and adults more frequently. The major drug in this category of non-amphetamine treatments for ADHD is modafinil, which is also called by its commercial name Provigil. There's a variant on this, which is armodafinil, which goes by the brand name Nuvigil. The major difference between modafinil and armodafinil, aside from having a slight chemical difference, is that modafinil was released first. Armodafinil is the second in the generation of these drugs. And modafinil tends to be very expensive. That's one of the reasons why it's prohibitive for some people to take. It can be as expensive as $25 a pill or more, so more than $1,000 per month. And armodafinil tends to be far, far less expensive. I've talked to a couple experts about whether or not there are any genuine differences between these two drugs, and they report no, although consumers of these drugs, for whatever reason, whether or not it's placebo or not, report yes, there is a difference. When I say placebo, I in no way mean that these drugs are just acting as placebo. I just mean that, people tend to get very attached to certain drugs and whether or not the brand name or the generic version works better for them. There's all sorts of lore about this. In fact, there are a lot of people out there who strongly feel that brand name Adderall works better than generic Adderall for them. There are a lot of people out there who say the same thing about Vyvanse. There are a lot of people out there who say the same thing about Ritalin and all sorts of drugs. Whether or not that's true or not is unclear. It is clear that generic versions of drugs can use binders and other things that are in the pill or capsule that are different than what the brand name pill or capsule uses as binders to hold the drug together, and that can impact rates of release and metabolism, etc. But a lot of this is just lore. In fact, I went into the literature to try and find any real concrete support for the idea that generic Adderall is less potent or less effective than brand name Adderall. And despite the tens of thousands of people who will say to the contrary, I could not find any peer-reviewed published data about that. So who knows? Maybe it's a belief effect, as it's called. Maybe there's a real difference there. Nowadays, modafinil and armodafinil are prescribed for a huge range of daytime sleepiness issues. We're talking about narcolepsy, but there are also people who suffer from daytime sleepiness related to dementia, daytime sleepiness related to post-surgery anesthesia. So there's this thing where people have surgery and then they come out of surgery and they feel better for a few days, but then they find that they aren't recovering their normal levels of wakefulness. So it's prescribed sometimes to try and get people back into a normal state of wakefulness. It's been prescribed for traumatic head injury, after stroke. Again, all of these prescribed uses have to be carried out by a certified physician. You really don't want to start cowboying the use of modafinil or armodafinil or any other prescription drug for that matter. I must say that in discussing all these different drugs during today's episode, I have zero knowledge of any of these drugs from a firsthand experience except for armodafinil. Back in 2017, I was prescribed a very, very low dose of armodafinil for jet lag, for daytime sleepiness issues, really, when I was traveling overseas to give a talk. So armodafinil was given to me in a 25 milligram tablet. It was advised to me that I take a half or even a quarter of that. So I started with a quarter. I am a believer in minimal effective dose. I'm also somebody who's fairly hypersensitive to most medication. So I took what I measured out to be 5 to 7 milligrams of armodafinil. And what I experienced was pretty profound. Certainly, it relieved any daytime sleepiness. In fact, it made me feel extremely alert for a period of about 4 to 6 hours. I can't say it was the most comfortable state, although I did not feel as if I had a racing heart or anything of that sort. I basically felt as if I was in a narrow tunnel of attention for that entire period. One thing I did not like about the experience is that it was a very hard experience to come down from. There was no crash, but I found that that high arousal state didn't taper off for many hours later. Even though it was most heightened for 4 hours, I would say anywhere from 8 to 12 hours later, I still felt like I was, blinking once every 4 minutes or so. And I've certainly been accused on this podcast and at other times of blinking too seldom. To my knowledge, I don't have ADHD. I've never been prescribed ADHD meds. I've never been tested for ADHD. I don't think I have ADHD. And yet taking modafinil certainly increased my levels of attention, but at least by that one experience, it's not something that I would want to repeat again. I certainly would not want to be in that state for learning new material. When I sit down to research a podcast or research papers in my lab or forage for information or learn from people or books or lectures or podcasts, I want to be in a state of alertness but calm, where I can really consider the ideas, where I can script things out by hand. I'm a big believer in writing things out by hand to remember them later, drawing little diagrams. I would not want to be in the state that even that very low dose of modafinil put me in order to learn. And I should mention that both modafinil and modafinil are associated with a good number of side effects if they don't agree with you or if the dosage is too high. Things like decreased appetite, people can get a runny nose, headache. There's this instance of skin rashes. In fact, one of the reasons why modafinil and modafinil aren't more broadly prescribed is that there's a very rare skin condition in which people who have taken certain drugs, not just modafinil or modafinil, have developed these very severe burn-type blisters, and in some cases this can be fatal. This is, again, very rare, and it was observed in at least one patient who took modafinil as part of a trial for modafinil as a treatment for ADHD. It's called Stevens-Johnson syndrome. Please, if you are squeamish to images of skin abrasions and lesions and things of that sort, please don't look it up on the internet unless you're able to handle that, and maybe not at all. But the point here is that one of the reasons that modafinil and modafinil are not more widely prescribed for ADHD and that it's still only prescribed off-label is that Stevens-Johnson syndrome was flagged as kind of a potential risk, although the ADHD specialists that I spoke to are somewhat frustrated with that because they insist that the frequency of this syndrome that causes this skin rash that's sometimes fatal is no more frequent in those that took modafinil in this trial than with other drugs that have been approved. So this gets into all sorts of issues around what drugs make it to approval and which ones don't. And as we know, modafinil and modafinil are already being prescribed in the general population for other things. This was dealing specifically with the question of whether or not it should be prescribed in kids with ADHD. And certainly I am a proponent of exerting extreme caution when thinking about which drugs should be approved for the treatment of anybody, but especially kids. And to round out our discussion of drugs used for the treatment of ADHD that fall into, let's call it the atypical category, right? The typical category being Adderall, Vyvanse, methylphenidate, and things of that variety. The less typical would be modafinil, modafinil, bupropion, Wellbutrin, and so forth. The last in this category of atypical is guanfacine. Guanfacine is an interesting compound. It's a compound that was developed to lower blood pressure, and indeed it does lower blood pressure. And it is an alpha 2A agonist, alpha 2A being a receptor for norepinephrine. So guanfacine is a non-stimulant medication to treat ADHD, and it's also used to treat some other conditions as well, that is only working on the noradrenergic system. It is not tapping into the dopamine system. But all the other stuff that we talked about is really ramping up dopamine and norepinephrine. Guanfacine is only increasing norepinephrine, and it's doing so by what we say agonizing or stimulating one particular aspect of the noradrenergic system, and that's the alpha 2A system. What's interesting about guanfacine is that it has a bunch of pathways that it activates that feed back onto the autonomic nervous system to dampen down the activation of the sympathetic nervous system. So whereas most of what we talked about today are sympathomimetics, they tend to make us more ramped up, more aroused and alert. guanfacine is doing the opposite. And as a consequence, it's not prescribed that often because a lot of times when people take guanfacine, it either has no effect on ADHD symptoms or it tends to make people feel very sleepy. However, there's a small subset of individuals, probably about 5 to 10% of people that try it, including kids, that do get some significant relief from their ADHD symptoms, and they seem to tolerate guanfacine better than they're tolerating some of the other drugs that we've talked about up until now. The way guanfacine works is also really interesting. You're now familiar with the locus coeruleus, this little packet, or we call it a nucleus of neurons in the back of the brain that release norepinephrine at other sites in the brain. And they're going to be those alpha 2A receptors that guanfacine works on and stimulates. Lots of different places in the brain related to increasing salience and relevance of particular stimuli that we see and that we need to attend to. It appears that guanfacine can activate the prefrontal cortical networks in ways that are above their normal baseline. So that's good. So improvements in executive function, that orchestra or teacher-like function we talked about before, and can increase the efficacy of that output from locus coeruleus. And what that seems to do is increase the coordinated firing of locus coeruleus neurons with prefrontal cortex. So in many ways, it's acting like a fine-tuning of that orchestra conductor operation that is so valuable in teaching these brain circuits during childhood of how to attend to one thing and ignore everything else. So this is one reason why guanfacine is now approved not just for adults with ADHD, but is primarily used in kids aged 6 to 17 years old for the treatment of ADHD, again, with the hope that these kids can take the drug and these circuits can learn how to focus and how to attend to certain things and limit impulsivity and hyperactivity, and then perhaps come off the drugs, although sometimes, again, people have to stay on them indefinitely. The other thing about guanfacine is that because it lowers blood pressure and it has this effect of kind of dampening down overall sympathetic arousal, sometimes it is prescribed in conjunction with other ADHD meds. So yes, there are kids out there and adults out there who are taking Adderall and guanfacine, or they're taking Vyvanse and guanfacine, and this is where it starts to get into drug cocktails and a bunch of other things that gets everybody a little bit uncomfortable, I think, because the idea of taking one drug to dampen down the side effects of another drug and to offset things and compensate, is getting towards what's called polypharmacology. And, I think it's understandable that people be concerned about that. And yet, again, in reviewing this with some of the experts on ADHD, there do seem to be a certain category of children out there and adults who really struggle with the standard ADHD meds. And in that case, guanfacine has provided a certain number of these individuals tremendous relief. One note about guanfacine: in no way, shape, or form am I encouraging anyone who's not prescribed guanfacine to take it. But should you know someone who's taking guanfacine off-label in order to improve their focus or enhance any aspect of their biology or psychology, please let them know that it has a profound effect on lowering the tolerance for alcohol, such that even small amounts of alcohol can lead to really serious problems and even potentially death. So that's a very serious warning with guanfacine. So today we discussed a lot of different compounds for the treatment of ADHD, and it now should become clear what the general themes of those compounds is. The general theme is that they tend to increase overall levels of arousal and wakefulness, which leads to decreased levels of hyperactivity, impulsivity, and focus. And on the face of it, that might seem counterintuitive. Raise arousal to reduce hyperactivity and impulsivity. Indeed, that's the case, because these compounds, because they act on neuromodulator systems like dopamine and norepinephrine, are effective in creating neuroplasticity. They change the strength of the connections in the neural circuits of the brain that lead to states of heightened focus and reduced impulsivity and reduced hyperactivity. So we talked about the different mechanisms by which the different medications for ADHD accomplish this, both the typical sort like methylphenidate and Adderall and Vyvanse, and some of the atypical compounds that are now being used in addition, such as modafinil, armodafinil, guanfacine, and Wellbutrin. And where possible, I tried to highlight both the short and long-term effects of these various compounds. And I tried to address some of the major concerns about these compounds, most notably the question of why are we putting so many kids on amphetamine and what is the long-term consequence of that? And throughout today's episode, I tried to highlight both the immediate and long-term benefits, but also the immediate and long-term risks that can exist with these compounds. Certainly when taken without a prescription recreationally, there is a real risk for abuse and addiction, as well as even a risk for psychotic episodes, but also the risks that accompany long-term use of these drugs in people with ADHD. And yet, it is also clear that not treating the symptoms of ADHD carries significant risk as well. And what's very clear from the scientific and clinical literature, and is covered in a significant amount of detail in the episode that I did about ADHD, which you can find at hubermanlab.com, is that combinations of drug treatments and behavioral protocols seem to surpass either drug treatments or behavioral protocols alone, speaking to the tremendous importance of combining multiple methodologies when treating ADHD and working with a board-certified psychiatrist who really understands ADHD and is really up to date on all the latest scientific and clinical literature. If you're learning from and or enjoying this podcast, please subscribe to our YouTube channel. That's a terrific zero-cost way to support us. In addition, please subscribe to the podcast on both Spotify and Apple. And on both Spotify and Apple, you can also leave us up to a 5-star review. Please also check out the sponsors mentioned at the beginning and throughout today's episode. That's the best way to support this podcast. If you have questions for me or comments about the podcast or suggestions about guests you'd like me to include on the Huberman Lab podcast, please put those in the comment section on YouTube. I do read all the comments. Not so much on today's episode, but on many previous episodes of the Huberman Lab podcast, we discuss supplements. While supplements aren't necessary for everybody, many people derive tremendous benefit from them for things like improving sleep, hormone support, as well as focus. The Huberman Lab podcast is proud to have partnered with Momentous Supplements. If you'd like to see the supplements discussed on the Huberman Lab podcast, you can go to Live Momentous, spelled O-U-S. So it's livemomentous.com/Huberman. If you're not already following me on social media, I am Huberman Lab on all platforms. So that's Facebook, LinkedIn, Twitter, and Instagram. And on all those platforms, I post about science and science-related tools, some of which overlaps with the content of the Huberman Lab podcast, but much of which is distinct from the content on the Huberman Lab podcast. So again, it's Huberman Lab on all social media platforms. If you haven't already subscribed to our Neural Network newsletter, the Neural Network newsletter is a monthly newsletter in which we distill down the essential points of particular podcasts and we list out toolkits, such as toolkits for sleep, toolkits for neuroplasticity, toolkits for optimizing dopamine, and on, all of which is available at zero cost. You simply go to hubermanlab.com, go to the menu, scroll down to newsletter, and supply your email. And we do not share your email with anybody. Thank you for joining me for today's discussion, all about pharmaceutical interventions for the treatment of ADHD. And last, but certainly not least, thank you for your interest in science.